Welcome back to the second part of our endocrine lecture. We're going to pick up with some of our target glands and tissues and exactly what they do. So we're going to start with the thyroid gland. One, it is a butterfly-shaped gland, and its location, number two, is inferior to the larynx and anterior to the trachea. It has a right and left lobes that are connected by a bridge. That bridge is called the isthmus. So if we were to take a pen and highlight in black the isthmus and our left and right lobes. Now, it reaches around the trachea and doesn't touch in back. Now, some glands also have a pyramidal lobe projecting from the isthmus. From a histological component, we're going to look at slides of the thyroid gland in a little bit, but the thyroid gland are made up of follicles. Those follicles are made up of follicular cells, which when stimulated are going to produce thyroxine, which is also known as T4 or tetraiodothyronine, and triiodothyronine or T3. These are our thyroid hormones. Now recall that the anterior pituitary hormone, thyroid stimulating hormone, is the hormone that is stimulating these follicular cells to produce these hormones. Now, it's a little misleading because the cells do not actually produce the hormone. The cells produce, what cells produce? A protein. Okay, and we'll talk about that protein in a little bit. We'll name it and see how it turns into T3 and T4. Now, in between those follicles are another grouping of cells called parafollicular cells. They're also known as clear cells or C cells. All right, C cells or clear cells. Now, these para means between, parafollicular cells produce a hormone called calcitonin. Now, the root word you see here, thinking ahead, is calcium. So we can say that this hormone is going to help regulate calcium homeostasis. Now we'll see exactly what it does in a little bit. So let's take a look at the thyroid two ways. First, from a gross anatomy perspective, where we have our isthmus, and there's that pyramidal lobe of the thyroid gland, the left and right lobes here. Now, we go to histological view, and what do we see? This resembles our kidneys, right? All those simple cuboidal cells forming tubes. The difference is inside is this pink gelatinous colloid, okay, this protein-based gelatin. So what's happening here? These follicular cells, so we'll highlight our follicular cells. These follicular cells are making a protein. The protein is thyroglobulin. So let's write this as being a protein. Now the protein is secreted into the lumen of that tube and it forms the colloid. Now that protein is what's going to be converted to T3 and T4 through a process we're going to look at on our next slide. Now the next cell we're going to look at are the cells in between our follicles called parafollicular cells. Now these parafollicular cells, we'll highlight them in blue, are going to be making another hormone called calcitonin. And again, we'll talk about exactly what they do in a little bit. So we're going to resort back to a picture of what's going on in the thyroid. So that old saying, a picture speaks 1,000 words. Well, for here, it really does. So we're going to start with a couple places, a couple things. So number one, and I know we're not really following this picture, but I want to start at the synthesis of thyroglobulin. So typical cell has its rough endoplasmic reticulum is making a protein. That protein is thyroglobulin. That thyroglobulin is going to move to the Golgi, which is going to package it into nice, neat little vesicles and then exocytize it into the actual lumen of that tube. And there it is. There's that thyroglobulin. Now, this protein has to be converted to T3 and T4. So exactly how does that happen? Well, we need another ion. That ion is iodide. So we need iodide in our diet because it's necessary for cleaving and creating these hormones from this protein. So where does iodide come from? So we can go to salt, and when you buy salt, it says iodized salt. So again, we are aware of the need for iodide, and we know that it's not naturally occurring in our diet unless we have a diet rich in fish, where we do find some iodide in fish. But we put it in the salt that's in pretty much every food, all foods that you eat. Now, the T3 and T4 are going to be synthesized through 8 steps. So what happens? You eat a diet rich in iodide, it's trapped here through the blood at the thyroid gland, and it's moved into the cell. Once into the cell, it's going to move into the colloid, so we follow it into the colloid, at which point we're going to see the oxidation of iodide. Now, once that iodide is oxidized, we're going to see that it's going to assist in the iodination of tyrosine. The iodination of tyrosine causes a coupling of T1 and T2. Now, that coupling is going to be drunk, so this is cell drinking, so that cell is going to reach out, drink the colloid, so pinocytosis and digestion of the colloid. Now here comes one of our cellular organelles. Our lysosome is going to attach to that portion of colloid that has been drunk, and it's going to break it apart into T3 and T4. Now that T3 and T4 is going to be secreted into the blood. Now we have an issue. Remember that T3 and T4 are lipid soluble hormones, so they cannot travel through the blood on their own. So what do we need? Once T3 and T4 are in the blood, we're going to see our transport protein, thyroxine binding globulin. So if we zoom on in right here, thyroxine binding globulin will bind to T3, thyroxine binding globulin will bind to T4, and it'll move through the blood to its target cells. Once it's in the blood, what is the target of these cells? What do they do? So thyroid hormones, specifically T3 and T4, are going to increase basal metabolic rate. And they do this by monitoring oxygen consumption by cells. Oxygen consumption by cells. So this is going to serve a couple of avenues. It's going to help to maintain normal body temperature. It's going to help stimulate protein synthesis for repair and growth. It's going to increase the use of glucose and fatty acids for ATP production. So this is cellular energy. We're going to upregulate beta receptors that attach to ketocholamine's. And lastly, we see a synergistic effect where it works with growth hormone and insulin to accelerate and exacerbate the body growth system. Let's continue with the thyroid gland by looking at its feedback loop. So as an overview, thyrotropin releasing hormone is released from the hypothalamus, which stimulates the release of thyroid stimulating hormone from the anterior pituitary, which will stimulate synthesis and release of thyroid hormones in this 5-step process we see to the right. So number 1, what's the stimulus that's being detected? Low blood levels of T3 and T4 or low metabolic rate is going to stimulate thyrotropic releasing hormone. TRH is going to be carried through the hypophyseal portal system, the portal veins, to the anterior pituitary to stimulate release of thyroid stimulating hormone by those thyrotrophic cells. The anterior pituitary releases TSH, it travels through the body and goes to the thyroid, affecting the follicular cells. T3 and T4 is going to be released into the blood by follicular cells via that 8-step process that we just got finished discussing. Now, here's our negative feedback. Because we are increasing levels of T3 and T4, these elevated levels are going to inhibit the release of thyrotropic releasing hormone as well as thyroid stimulating hormone. This is that negative feedback loop. So it kind of shuts this system down. So again, negative feedback loop. Table 18.6 breaks apart the thyroid gland, looking at the hormones, source, as well as control of secretion and what they do. So we didn't really talk about calcitonin, so I'm going to take some time to talk about this. Now, calcitonin's job is to deal with calcium levels in the blood. So exactly what happens? So when we have high levels of calcium in the blood, we're going to see calcitonin coming out and being secreted to remove 99% of this calcium and send it essentially to the bones. So what does calcitonin do? It monitors, so we'll say it monitors the upper limits of calcium in the blood by reducing, and we'll put a lower arrow, blood calcium levels. So we're going to jump ahead. I just want to introduce something. Now, typically, we're going to see this twice in this lecture. Anytime we have an up-down scenario physiologically in the blood where we're monitoring the upper limits by reducing something, remember there's balance in biology. We need to have something else that is going to monitor the lower limits by increasing. So what is this called? We'll draw a double arrow here. This is called antagonistic hormones, and we introduced this at the beginning of our first lecture. So here's calcitonin. It lowers blood levels of calcium by inhibiting bone resorption by osteoclasts and by accelerating uptake of calcium and phosphates into the bone extracellular matrix. So again, 99% of that calcium is going to bones. The next gland we're going to talk about is the parathyroid gland. Now, it is located on the posterior back aspect of each lobe of the thyroid, and there are two parathyroid glands, one inferior and one superior. So let's zoom on in, and here we go, where it wraps around the trachea. There it is, 1 spot, 2 spot, 3 spot, 4 spots. Now, we're going to see that this is important. And why is it important? The reason why is because they are and look like they're attached. They're actually not. They are neighbors, right? So it's kind of like, look at your neighbor next door to you. Are they related to you? Most likely not. But do they live next to you? Yes. Well, that's the thyroid and the parathyroid. They occupy similar areas, they live next door to each other, but histologically completely different. So we say, well, histologically, what does it look like? Well, we see the majority of the thyroid is made up of clusters of cells called chief cells. Now, these are the principal cells, so you'll also see that they are called principal cells, okay? Principal cells. Now, the other cell that we see are oxyphil cells. Now, our oxyphil cells tend to aggregate around the border of the thyroid. We know in utero they're pretty active to make the hormone that the chief cells make, which is parathyroid hormone, PTH. But once the baby is born, the chief cells are at high enough count, they start taking over. We also know that if a tumor grows within the chief cells, that the oxyphil cells kind of take over and then start producing the majority of the PTH. But our chief cells here are those key players, our principal cells that's going to make parathyroid hormone. So elaborating on our two types of cells that we just talked about, our chief cells, also known as principal cells, produce parathyroid hormone, also known as parathormone. The oxyphil cells, it's a big question mark, right? We don't really know what it does in the normal parathyroid, but we know it secretes excess PTH in cases of parathyroid cancer. A closer look at the histology of the parathyroid gland. Again, we see our chief cells, our principal cells, and hanging off to the side, these more clearer, larger oxyphil cells. So we're going to talk a little bit about this antagonistic effect. So let's write these words. These are key words, antagonistic effect. So these are antagonistic hormones. So calcitonin, the antagonist to parathyroid hormone produced by the thyroid gland, works in conjunction with PTH and calcitriol from the kidneys to regulate calcium homeostasis. So how exactly do they do that? So let's start with number one, a scenario. High levels of calcium in the blood stimulate thyroid gland parafollicular cells to release more calcitonin. As a result, calcitonin inhibits osteoclast activity while decreasing blood calcium levels. So right here. These low blood calcium levels stimulate the parathyroid gland chief cells to make parathyroid hormone. Parathyroid hormone promotes the release of calcium from the bone extracellular matrix into the blood and slows the loss of calcium in urine, ultimately increasing blood calcium levels. So where is the negative feedback loop? Now, PTH also stimulates the kidneys to release calcitriol. Calcitriol is going to stimulate increased absorption of calcium from foods, which increases blood calcium levels, which will bring us back to a high level of calcium in the blood. So we could put it all together into a nice neat table, 18.7, the parathyroid. Let's write it out though. So the parathyroid gland, the chief cells in the parathyroid gland secrete PTH. Okay. Now PTH's job is to monitor the lower limits of calcium in the blood, by increasing blood calcium levels. Okay, so how does it do that? So it increases blood calcium and magnesium levels and decreases blood hydrogen phosphate levels, increases bone reabsorption by osteoclasts, increases calcium reabsorption and hydrogen phosphate excretion by kidneys, promotes formation of calcitriol, which is our active form of vitamin D, which is ultimately going to increase rate of dietary calcium and magnesium uptake or absorption. So here's the antagonist, the down-up, whereas calcitonin is the up-down. So again, we see our antagonistic hormone sets. We're going to finish up the thyroid by talking about some thyroid gland disorders. The first is a congenital disorder called congenital hypothyroidism or cretinism. This is underactivity of the thyroid gland at birth. Now, this is pretty detrimental to fetal and childhood development. It results in growth retardation, developmental delays, as well as other abnormal features. Now, the interesting note about cretinism is that it seems like it could be due to deficiencies of iodine in the mother's diet during pregnancy. So we see how important iodine is to the thyroid and thyroid health. A second example of hypothyroidism is found in adults, and it's called myxedema. Now, the symptoms of myxedema include thickening of the skin and other symptoms that are typically associated with hypothyroidism. Now, this includes fatigue, weight gain, depression, dry skin, and brittle hair. Now, that skin thickening that we just talked about, or swelling that's associated with myxedema, is often used, we could describe this in other ways, it's called non-pitting edema. The next condition we're going to look at is Graves' disease. Now, we see this in the picture off to the right, in the upper right, where the eyes are bulging, also known as exophthalmosis. Now, Graves' disease is an autoimmune hyperthyroid disorder, right? So autoimmune means our immune system is attacking itself. And as a result, the immune system, the thyroid, becomes hyperactive. And as a result, this hyperthyroidism causes the tissues around your eyes, especially the connective tissue, to become inflamed and essentially pushes the eyeballs out of the socket, causing this bulging eye effect. Now, there are a few other symptoms, common symptoms of Graves' disease, and these things include things like anxiety and irritability. Sometimes patients will exhibit fine tremors of the hands or fingers, and also we see some heat sensitivity and an increase in perspiration of warm, moist skin. The last thyroid disorder we're going to look at is goiter. Now, goiter is a really interesting condition. What happens is the thyroid becomes enlarged, and we say, well, how does that happen? Let's go to some third world countries where people do not have access to things like iodized salt or fish that have a lot of iodine. And we see populations of people having iodine deficiencies. Now, remember, iodine is one of those rate-limiting steps where we have to trap into the thyroid, from the blood into the thyroid, in order to make T3 and T4. Now, if you do not get iodine into your system, your cells are still making the protein thyroglobulin, and because it can't be cleaved and subsequently pushed into the blood to be used by the metabolism, we see that the protein tends to swell and enlarge those follicles. And as a result, the thyroid grows and grows and grows and grows, and it will keep getting bigger and bigger and bigger until treated. Parathyroid gland disorders. The first disorder we're going to look at is hypoparathyroidism. Now, hypoparathyroidism occur when we get low levels of calcium in the blood. Now, the severity of the condition can range from mild symptoms such as things like tingling or numbness in the fingers, toes, and even around the lips. This is called paresthesia. Or it could get really severe, which could lead to severe muscle cramps or muscle spasms. Now, there's a pretty easy way to test for hypoparathyroidism. So if you look at this little tutorial below, we can ask our patient to relax his facial nerves. We're going to stand directly in front of him or her and tap that facial nerve either just anterior to the earlobe or below the zygomatic arch and the corner of the mouth. A positive response varies from twitching of the lip at the corner of the mouth to spasms of all facial muscles. And this is going to depend on the severity of the hypocalcemia, so how low our calcium levels are. Following hypoparathyroidism, it makes sense to discuss hyperparathyroidism, so an overactive parathyroid. Now, with this condition, the symptoms usually take a really long time to develop, but when they do occur, they include more commonly things like fragile bones, kidney stones, and excessive urination. But we can see the effects of hyperthyroidism on the entire body, like the brain, where we get depression, drowsiness, fatigue, thirst, confusion, seizures, and this is again due to increased calcium in the blood. In the urinary tract, again, kidney stones, frequent urination, higher volume of urine, again, increased calcium in the blood. Now, our bones are affected. We see osteoporosis or weakened bones, and this can lead to our bones being more easily fractured, and that's because we are pulling that calcium out of the bones and putting it into the blood. For our tissues, joint inflammation, muscle weakness, again, we're getting calcinosis, which is deposits of calcium salts in our tissues, muscles, and joints. And then our digestive tract, because of this increase of calcium in the blood, we get things like nausea, vomiting, constipation, stomach pain, gas, and even possibly pancreatitis and ulcers. The next glands we're going to look at are the adrenal glands. So first location, we break apart the word adrenal. So we're talking about on top of the kidneys. So ad means on top, renal means kidney. So we're on top of the kidneys. They're also known as suprarenal glands for superior to the kidneys. And again, their location right here, retroperitoneal, on top of our two kidneys. Now, the glands are covered by a connective tissue capsule and are divided into two regions. The first region is the cortex, and the cortex is this outermost region from here to here. Okay? That brings us to the second region, which is the medulla. And we're going to shade in the medulla for you in blue, and it is this innermost region. Okay, now we're not really going to talk about the medulla that much because we discussed the medulla in length with the specific types of cells, the chromaffin cells here that are making norepinephrine and epinephrine, aka adrenaline, right? And we talked about sympathetic innervation, so the sympathetic nervous system, and how that had that rare circumstance where we bypass the chain and go directly to the adrenal medulla for fight or flight response. Okay, our focus for the hormones here for this system, specifically from the anterior pituitary, is the effect of adrenocorticotropic hormone. There's that word cortico that affects the three layers of the cortex. So that's really what we're going to focus on in our lecture. Now again, we're going to focus in on the histology of the cortex. So we're going to zoom right into here. We're going to outline and kind of get rid of the adrenal medulla. So that's this all down here. So we're going to get rid of that. Again, we're focusing up here on the adrenal cortex. The three layers that make up the cortex, and again, they're named after their appearance. Before we get into that, let's remember that there is a fibrous capsule. Okay, so we get this connective tissue capsule that lines. So again, see that little yellow that's lining the gland? Well, histologically, we see it right here. So we can write our capsule is right here. I know it's right to my right over there as well, but since we're zoomed in, let's take a look. So our first zone is called the zona glomerulosa. So we see our zona glomerulosa. We'll highlight it in yellow here. Now that zona glomerulosa is called glomerulosa because of its appearance. So let's take a look. Glomeruli means balls. So we see these ball-like structures in this first and one of the smallest zones that we talk about. Now, the zona glomerulosa makes a class of hormones. So, class of hormones called mineralocorticoids. Now, the actual hormone secreted is going to be mainly aldosterone. And we'll talk about what aldosterone does in a little bit. The next region is the zona fasciculata. Now you should recognize this root word. Fasciculata sounds like fascicles. So this layer is put into these long bundles, these long fascicles, and it gives a more lighter appearance when you look at it under the microscope. Now this zone secretes again, we're going to talk about class of hormone called glucocorticoid, and the major hormone that's going to secrete is going to be cortisol. Now, the last layer that we're going to talk about is one of the smallest layer. It's called the zona reticularis, so we'll highlight that in red for you. Now, the zona reticularis is called that because it gives this branching appearance like reticular fibers. Now, the class of hormones that it's going to secrete, so again, class of hormones it's going to secrete, are androgens. And one of the major hormones is going to be, so we'll write hormones here, is going to be dehydroepiandrosterone, DHEA. Now, this hormone is in such small quantities that we really term it, and we're going to write insignificant. However, we're going to see that DHEA plays a really important role in synthesizing estrogen and androgens. Now, why would this be important? Well, when females enter menopause and a lot of their secondary structures like their ovaries and structures that contribute to the amount of free circulating estrogen in the body stop ovulating, the amount of estrogen decreases. So this region, this DHEA, kind of is released and takes over for supplementing a lot of that estrogen for the females. So we can elaborate on each of the zones. We start with the zona glomerulosa. Remember, it secretes a class of hormones called mineralocorticoids. That main hormone is going to be aldosterone, which is used to regulate mineral homeostasis. So what minerals are we talking about? We're talking about the amount of sodium that is being pushed back into the body or the bloodstream. Also, the amount of potassium that's going to be released in the urine. Now, overall, aldosterone affects the body's ability to regulate blood pressure, and it does this, again, primarily by increasing the amount of sodium the body sends into the bloodstream. The second zone, the zona fasciculata, secretes, again, the class of hormones, glucocorticoids, the main hormone being cortisol. Now, this ultimately affects glucose homeostasis. Now, remember, because most body cells have cortisol receptors, it affects a multitude of functions in the body. Now, cortisol ultimately can help control blood sugar levels, it regulates metabolism, helps to reduce inflammation, and assists with memory formation. It also has a controlling effect on salt and water balance, which ultimately helps to control blood pressure. Now, I want to zoom on in and focus in on reduced inflammation. Remember, if you've ever had a cortisone shot at a doctor, they inject those shots into your joints. Again, the goal is to reduce inflammation. Cortisone is essentially cortisol. That's all it is in an injection liquid format. Now, the third region we're going to look at is the zona reticularis. Again, we're secreting a class of hormones called androgens. It's weak, so the hormone is dihydroepiandrosterone, and again, the action is relatively insignificant. Overall, hormones secreted here give us a masculinizing effect. So we're going to focus in and look a little more at aldosterone, being that it's one of the more major mineralocorticoids secreted by the adrenal gland. As a repeat, as we introduced in our last slide, it's going to help regulate sodium and potassium homeostasis. Now, it plays a major role in the renin-angiotensin-aldosterone system. Now, remember, aldosterone essentially acts on the tubules in the kidney, causing them to reabsorb more sodium and water from the urine. This ultimately is going to increase blood volume, which will then subsequently increase blood pressure. So our next slide looks at the entire cascade for the renin-angiotensin-aldosterone system. Again, to reiterate, our renin-angiotensin-aldosterone pathway, its main goal is to increase blood pressure and ultimately blood volume. So how does this happen? What is being detected? We start with number 1. So right here, we are detecting dehydration, sodium deficiency, or hemorrhaging. As a result, there's a decrease in blood volume. That decrease in blood pressure is detected at our blood regulators. These are the kidneys, so the juxtaglomerular cells of the kidneys. As a result, the kidneys are going to secrete renin. Renin is going to work with angiotensinogen that's being secreted from the liver to increase angiotensin 1. Now, the lungs produce an enzyme called ACE, angiotensin converting enzyme, that converts angiotensin 1 to angiotensin 2. Angiotensin 2 has 2 targets. One, it's going to target the adrenal cortex as well as vasoconstriction of the arterioles in the body. With regards to the adrenal cortex, it increases, there's our aldosterone, increases aldosterone, which, as we said before, it focuses on the kidneys to increase sodium and water reabsorption and increase in secretion of potassium and hydrogen into the urine. This is going to increase blood volume, which would increase blood pressure until our system returns to normal. Now, this increased potassium in the extracellular fluid will also be detected by the adrenal cortex, increasing aldosterone. Now, as far as that vasoconstriction of arterioles goes, it's going to increase, blood pressure is going to increase until it returns to normal. So again, there's our goal, there's our aim, to increase blood pressure and blood volume until we get normal level, at which point this system will be shut down. Now again, we put to type what we talked about before. Cortisone, hydrocortisone, this hormone in this class of glucocorticoids, is the most produced, is regulated by negative feedback. What does it do? And again, just putting it to type what we talked about before, it helps protein breakdown, glucose formation, lipolysis, resistance to stress. We've talked about its effect with inflammation and the clinical connection between cortisone and immune responses. We can look at the regulation of glucocorticoids, its feedback loop. So we have a stimulus that is disrupting homeostasis by decreasing glucocorticoid levels in the blood. As a result, the receptors, the neurosecretory cells, and the hypothalamus detect this, increase corticotropic releasing hormone, and decrease cortisol. The corticotropes in the anterior pituitary are going to increase output of adrenocorticotropic hormone. It's going to affect the cells of the zona fasciculata in the adrenal cortex to secrete cortisol, to secrete that glucocorticoid. The response is increased glucocorticoid in the blood. This returns to homeostasis when the response brings glucocorticoid levels back within normal range, and the loop shuts down or negates. Again, elaborating on our dihydroepiandrosterone, this is that major androgen that's secreted by the adrenal cortex, specifically the zona reticularis. In males, after puberty, the hormone testosterone is secreted in much larger quantities, so DHEA has virtually no effect. That's why we said it was insignificant. In females, DHEA and other adrenal androgens play a major role in promoting libido and are converted to estrogens. In menopausal women, all female estrogens come from the adrenal androgen. So as we said before, when women reach menopause, this layer is specifically important to estrogen production. Now, the last portion of the adrenal gland that we're going to talk about is the adrenal medulla. Now, again, we said that we were going to focus mostly on the cortex, but we do have to talk about this a little bit. We stated that it is stimulated by the sympathetic preganglionic neurons of the autonomic nervous system. So again, this is more associated with the autonomic nervous system. The cells are called chromaffin cells that secrete epinephrine and norepinephrine, adrenaline and noradrenaline, both of which are involved in the fight or flight. Again, recall one of our 4 ways that we get sympathetic outflow. This was one of them, bypassing the chain, going directly to the adrenal medulla for fight or flight fast response. Table 18.8 puts everything we've talked about in the past few slides in a nice, neat little package. All the hormones and their source, their control of secretion, and their principal actions. Our next step is to look at some adrenal gland disorders. The first that we're going to discuss is Cushing's syndrome. Now, Cushing's syndrome is a condition that occurs from exposure to high cortisol levels for a long time. So one example, one of the reasons why we can't take prednisone for an extended period of time, and doctors are pretty cautious about when and how long they prescribe it, is because under consistent and long exposure, Cushing's syndrome can occur. Again, the most common cause is the use of steroid drugs, but it can also occur from overproduction of cortisol by the adrenal glands. And this is pretty common, more than 3 million U.S. cases per year. Now, what are the symptoms? So the symptoms are typically seen in the whole body, like excessive sweating, excessive hairiness, excessive hunger, fatigue, flushing, high blood pressure, or osteoporosis. When we talk about the skin, abnormal pad or of fat between the shoulder blades, acne, darkening of the skin, stretch marks, or thinning. Now, muscular, we see muscle weakness or loss of muscle. Other common symptoms include things like anxiety, depression, bruising easily, hair loss, headaches, insomnia, irritability, infertility, potbelly, round face from gradual swelling, and swelling in the extremities in conjunction with weight gain. So the picture to the right is a good description or characterization of Cushing's syndrome. You can see the potbelly, the swelling, the vascularization, etc. The second condition we're going to talk about is Addison's disease. Now, Addison's disease is pretty uncommon. It is called adrenal insufficiency, and it occurs when your body doesn't produce enough of certain hormones. Those hormones include too little cortisol and also too little aldosterone. Now, as far as the symptoms for Addison's disease go, the symptoms usually develop slowly, and it usually takes several months for them to demonstrate. So because progression is so slow, symptoms are usually ignored until a stress, such as things like illness or injury, that makes the symptoms worse. So some of the symptoms for Addison's disease include extreme fatigue, weight loss, decreased appetite. You can get hyperpigmentation, which is darkening of your skin, low blood pressure that can lead to fainting, salt craving, hypoglycemia, which is low blood sugar, diarrhea, vomiting, or nausea, so any type of gastrointestinal symptoms, abdominal pain accompanying that, muscle joint pains, irritability, depression, body hair loss, or sexual dysfunction in women. The last condition we're going to talk about is pheochromocytoma. So this is a hormone-secreting tumor that can occur in or on the adrenal glands. Now, this is very rare. There are fewer than 20,000 cases per year in the U.S. It is treatable by a doctor, so you can get treatment, but it does require a medical diagnosis. Symptoms of pheochromocytoma include high blood pressure, headaches, heavy sweating, rapid heartbeat, tremors, your face could look pale, shortness of breath, or panic attack-like symptoms. Now, less common symptoms can include things like anxiety or sense of doom, constipation, and weight loss. The next organ or gland that we're going to look at is the pancreas. Its location is in the curve of the duodenum. It is both an endocrine and exocrine gland, and we're going to assign a percentage here. The percentage of exocrine, believe it or not, is 99%. The pancreas only serves a 1% function as far as secreting hormones into the blood. So we can look at the picture below, and we see our head of the pancreas as we work into our body and our tail. We'll talk about its anatomy in a little bit. Now recall that 99% of the pancreas is exocrine. So that means that the majority of cells that make up the pancreas are arranged in clusters called acini. So these acinar cells are the exocrine cells. They're producing digestive enzymes that are delivered to the intestinal tract through ducts. Remember, our definition of exocrine is pushing, for here digestive enzymes, stuff through ducts. Now, scattered among these acini are clusters of endocrine tissues called pancreatic islets. These pancreatic islets are also called islets of Langerhans. Now, the islets contains secretin cells, cells that are going to secrete stuff through the blood and act on the cells of the body. The islet cells include 4 types of cells that secrete different hormones. The first cells we're going to talk about are alpha cells. Now, the alpha cells make up about 20% of the cells within the islet. Their job is to make glucagon. Now, we're going to throw some consistency in here. Glucagon's job is to monitor the lower limits of sugar or glucose in the blood by increasing blood sugar levels, right? So here's that up-down scenario, okay? So remember, we're leading into, I'm teasing you with these antagonistic hormones, okay? Now, that brings us to beta cells. Beta cells make up about 70% of the cells within the islet. Their job is to produce insulin. Now, what does insulin do? Insulin monitors the upper limits of sugar in the body by reducing blood sugar. So there are our antagonistic hormones. The next cells are D or delta cells. They're a little less than 10%. They produce somatostatin, and somatostatin is going to kind of inhibit the F cells from producing pancreatic polypeptide, as well as the alpha and beta from producing glucagon and insulin. That brings us to our F cells. Our F cells are also called pancreatic polypeptide producing cells. Their job is to make pancreatic polypeptide. So these account for a little less than 5% of the cells in the islet. So we say, well, what is pancreatic polypeptide? The function of pancreatic polypeptide is to self-regulate pancreatic secretions. Now, this is going to self-regulate both the endocrine and exocrine, okay? Now, table 18.9 puts everything we talked about on the last slide, and again, a nice, neat little package. That's one of the great things about these tables. So if you've missed anything in my little discussion, you can pull out your information here. All the different cells, alpha, beta, delta, and our F or PP cells or pancreatic polypeptide cells, what they control for secretion and what their principal actions are. So again, a great table to kind of review everything. Now we can put it to a clinical description. What happens when we are in a hypoglycemic state or a hyperglycemic state? So let's see our control of negative feedback. Number 1, low blood glucose. So we're in a hypoglycemic state, stimulates the alpha cells to secrete glucagon. Glucagon acts on our liver cells, converting glycogen into glucose. So remember, our body cannot store glucose. It takes way too much water to store glucose, so we convert it into something that's more easily stored, which is glycogen, which means when we need to pull that energy, we have to convert it back to glucose. So we form glucose from lactic acid and certain amino acids. The glucose is released by the liver cells, raising blood glucose levels to normal. If blood glucose continues to rise, hyperglycemia inhibits the release of glucagon. Now, Let's go on the other side, the flip side. If we have hyperglycemia, high blood glucose, this is going to stimulate the beta cells to secrete insulin. Insulin acts on various body cells to, 1, facilitate diffusion of glucose into the cells, so we're uptaking sugar into the cells, speed the conversion of glucose into glycogen, increase uptake of amino acids, and increase protein synthesis. We're also going to speed the synthesis of fatty acids. Again, these are storage. We're storing this energy. Blood glucose level falls. If blood glucose continues to fall, hypoglycemia inhibits the release of insulin. So, how important is this relationship between insulin and glucagon? That 1% endocrine, does it play a vital role in the homeostasis of your body? Absolutely. And on our next slide, we're going to look at the pathologies that ensue as a result of imbalances with these two systems. So what disorder arises as a result of those alpha and beta cells? We start with type 1 diabetes mellitus. Now, this condition is an autoimmune disorder where your immune cells physically set out to destroy your beta cells, those cells that make insulin. So you enter into an insulin deficiency. As a result, your body has a hard time remediating and dealing with controlling blood sugar levels, and high blood sugar levels will consistently persist throughout the body unless treated. What are treatments? This is relatively manageable with a medical professional. You would use a diabetic pump or injections to alleviate or at least inject the required amount of insulin to remediate that blood sugar. Typically, the life expectancy is relatively good now with technology. Prior to the 1990s, before the invention of the insulin pump, type 1 diabetics, which were known as childhood onset diabetes mellitus, life expectancy didn't extend really past the early to mid 20s. Shows you how deleterious, how dangerous it is to have high sugar levels in your blood. It damages your eyes, your kidneys, your muscles, your circulation, the circulation to your extremities, etc. But again, now with technology, with diabetes pump, the insulin pump and other therapies, type 1 diabetes, people can live a long and healthy lifestyle. Now again, it was called juvenile onset, which means that it's usually diagnosed early on, all the way up to about 18 to 20 years of age. You can be diagnosed with type 1 diabetes. Type 2 diabetes used to be called adult onset diabetes mellitus. This is a condition where your cells stop responding to the signals from insulin, meaning that they stop allowing for this facilitated diffusion of glucose into the cells. Now, why would this happen? We talk about America and fast food, our fast food diet, and the high-paced lifestyle that we live today. And as a result, our poor food choices and high rate of obesity increases to high sugar content in our food and high sugar content in our diet, which in turn changes the anatomy of our cells and the physiology. So those cells are kind of start getting tired of seeing that signal, that stimuli from the sugar, and stop responding to the insulin. So an analogy I use is kind of you're away at college and you're kind of used to being on your own and doing your own thing. Then you go home and your parents expect you to follow the same rules, and they're on you and nagging you to clean your room, turn off the lights, and you just kind of start ignoring them. You tune them out, right? So that's exactly what the cells of your body do. They kind of tune out that stimulus, tune out that sugar, and then as a result don't respond to insulin, and this is bad. Treatment usually first and foremost would be weight loss, diet change, and exercise. So reducing weight can reduce the amount of sugar. Changing your diet, reduce the amount of sugar, and your cells will go back to a pre-diabetic state. The last case is gestational diabetes. This tends to occur when you're pregnant. Again, you'll be tested for this when you are pregnant. Females will have a glucose screening test to see how quickly you clear that glucose. If you test positive for gestational diabetes, you'll be treated with insulin during the duration of your term for 40 weeks. Babies tend to grow extraordinarily big, 7, 8, 9, 10, 11-pound babies. 96% of patients who have gestational diabetes usually have C-sections as well. If you do not treat this is not an option. All women will have a glucose screening test when they're pregnant. But if you do not treat this, babies are typically born musculoskeletal deficiencies, neurological deficiencies, blind, things like that. So not a good scenario to leave and let go untreated. The second to last structures we're going to look at are the ovaries and testes, or gonads. Now, the job of these structures are to produce gametes, oocytes and sperm respectively. Now, we're not going to go in too much depth about what these structures do, as we will get into it when we do reproduction, but let's look at some of the hormones. We start with the ovaries. They produce two types of estrogens, estradiol and estrone. We're also going to see progesterone being produced, relaxin, and inhibin. The testes are going to produce testosterone. This is going to give us our secondary sex characteristics in males, as well as contribute to the efficacy and production of sperm. So table 18.10 goes through these ovarian hormones, estrogen and progesterone. So together with gonadotropic hormones of the anterior pituitary, we're regulating female reproductive cycles, maintaining pregnancy, preparing those mammary glands for lactation, and promoting development and maintenance of female sex characteristics. Now, relaxin does exactly what its name implies. It relaxes or increases the flexibility of the pubic symphysis. Remember that fibrocartilaginous pad? So we're going to relax that during pregnancy, which is going to help dilate the uterine cervix and help ease labor and delivery. Inhibin does exactly as its name implies as well. It inhibits the secretion of follicle-stimulating hormone from the anterior pituitary, preventing further follicles from developing. For testicular hormones, we see testosterone. Again, stimulates the descent of testes before birth, regulates sperm production, promotes development and maintenance of male secondary sex characteristics. And inhibin for male is going to inhibit, again, FSH from the anterior pituitary. The last two are the pineal gland and the thalamus. Now, the pineal gland is attached to the roof of the third ventricle of the brain and is continuous with the epithalamus. It's secreting melatonin. Now, melatonin's job is going to help regulate the body's biological clock. The stimuli is the sun. When the sun rises and sets, the lack of sunlight will kick the pineal gland in action, secreting melatonin, telling your body it's time to go to sleep and enter into a parasympathetic response. The thymus. Now, this is an interesting structure. It is located behind the sternum between the lungs, above the heart, and produces a hormone called thymosin, thymic humoral factor, and thymic factor, as well as thymopoietin. These hormones promote maturation of the immune system's T cells. So, the thymus is essentially a nursery. Now, it's really active up until about the age of 2 or 3. After that, most of that organ is replaced with fat. Again, we're going to see it as a nursery, so the bones are going to make T cells. These T cells are going to allow to mature and differentiate in the thymus. We can use a picture to come full circle. Again, this is the same picture we showed on our first or second slide, where our pineal gland is. So we could zoom on in into the brain right there for the pineal gland, and just move up to find the thymus. Other endocrine tissues and organs, eicosanoids and growth factors. Now, there are several tissues and organs which are not part of the endocrine system, but they are able to produce and secrete hormones. Table 18.11 goes through these structures, the hormones, and their principal actions. So we are going to go through these a little bit because they are pretty interesting. The skin secretes cholecalciferol. This plays an important role in the synthesis of calcitriol, which we know is the active form of vitamin D, and helps to regulate bone calcium absorption. In the GI tract, or gastrointestinal tract, we deal with gastrin. This promotes secretion of gastric juice, increases motility and movement of the stomach. GIP, glucose-dependent insulinotropic peptide. This stimulates the release of insulin by the pancreatic beta cells. Secretin stimulates secretion of pancreatic juice and bile. CCK, cholecystokinin, stimulates secretion of pancreatic juice and also regulates release of bile from the gallbladder, causing that feeling of fullness after we eat. The placenta secretes human chorionic gonadotropin, HCG. Now, this is one of those major hormones that a pregnancy test uses to detect whether you are pregnant or not. So this stimulates the corpus luteum in the ovary to continue production of estrogens and progesterone, telling the body that we are pregnant. Estrogens and progesterone, again, maintain pregnancy, help prepare those mammary glands to secrete milk. And human chorionic somatomammotropin, or HCS, stimulates the development of mammary glands for lactation. The kidneys secrete renin, part of that renin-angiotensin-aldosterone system, which is part of the reaction sequence that raises blood pressure by bringing about vasoconstriction and secretion of aldosterone. EPO, erythropoietin, this is going to stimulate the increased rate of red blood cell formation. Calcitriol, there we go again, that active form of vitamin D, aids in absorption of dietary calcium and phosphorus. The heart secretes AMP, or atrial natriuretic peptide. This is going to detect overstretch of the atria, therefore decreasing blood pressure. Adipose, yes, the fat in our body secretes a hormone called leptin. This tells us when we are satiated. It suppresses appetite, and it also may increase FSH and LH activity. Eicosanoids are locally acting hormones. They're derived from 20-carbon fatty acids, arachidonic acid. Now, prostaglandins are one example of this biologically important class of fatty acids. They also include leukotrienes and thromboxanes. Now, exactly what do these eicosanoids do? They are particularly important in mounting or inhibiting inflammation responses. They also respond to allergies, fever, and other immune responses. Eicosanoids are also used in regulating the abortion of pregnancy and normal childbirth. They also contribute to the perception of pain, regulate cell growth, and ultimately, and also controlling blood pressure. Table 18.12 goes through some other summary of selected growth factors, ones that we have not talked about. We're going to briefly go over them, but I don't really expect you to know these. Epidermal growth factor, EGF. This is produced in the submaxillary salivary glands, which stimulates proliferation of epithelial cells. The second is platelet-derived growth factor, or PDGF. This is produced in blood platelets, stimulates proliferation of neuroglia, smooth muscle fibers, and fibroblasts, and has a role in wound healing. Fibroblast growth factor, again found in the pituitary gland and brain, stimulates proliferation of many cells derived from embryonic mesoderm. Nerve growth factor, produced in the submandibular salivary gland and the hippocampus of the brain, stimulates growth of ganglia and embryos, and maintains the sympathetic nervous system. Tumor angiogenesis factor, TAFs, produced by normal and tumor cells, stimulate growth of new capillaries, organ regeneration, and aid in wound healing. Transforming growth factor, this is TGFs, produced by various cells as separate molecules. TGF alpha, for example, has activity similar to epidermal growth factor, and TGF beta is going to inhibit proliferation of other types of many cells. Our next course of action is to discuss the stress response. We have two types of stress, good stress and bad stress, respectively. Eustress is our good stress. This is helpful stress. This is everyday stress that prepares us to meet the challenges, like the stress exerted on our body when we wake up, increasing blood pressure, increasing nutrients to our muscles, to our brain, to get us going for the day. Distress is harmful stress that can be damaging. This is chronic stress, so the fight or flight response, which is the first stage of the stress response, stimulates the body's resources to prepare for immediate activity. So a constant state of stress, right? It puts in a negative response, a constant exposure to cortisol, trying to negate the stress response, and as a result, we get this resistance reaction. This occurs in the second stage in the stress response and lasts a lot longer than fight or flight. If it lasts too long, exhaustion will result. So we can look at the feedback loop of the stress response. We have a stressor. And corticotropin releasing hormone, growth hormone releasing hormone, and thyrotropin releasing hormone is going to act on three major hormones of the anterior pituitary: thyroid stimulating hormone, adrenocorticotropic hormone, and growth hormone. And each will have a subsequent response. For TSH, the stress response is going to increase use of glucose to produce ADP, so we're stimulating metabolism. For the liver, insulin-like growth factors are going to be secreted, so this is stress response, increasing lipolysis and glycogenolysis. And for the adrenal cortex, we're going to be secreting cortisol, so this stress response also initiates lipolysis, so destruction of fat for energy, gluconeogenesis, so the creation of glucose, and protein catabolism, sensitized blood vessels, and reduced inflammation. Now, when we look at our nerve impulses, okay, the sympathetic centers in the spinal cord stimulate sympathetic nerves. We go to the adrenal medulla, secreting epinephrine and norepinephrine. This is giving us a fight or flight response, which brings us back into this category here of our visceral effectors. What happens with aging in our endocrine system? So the trend that we see with all of our systems is that aging brings about changes in the levels of most hormones. Now, some hormones level increase while others decrease. Levels of hormones like epinephrine and norepinephrine remain the same, but things like insulin and testosterone and estrogen tend to dissipate over time. Histologically, most endocrine glands reduce in size and contain increasingly more fibrous connective tissue with age. The next few slides go over some review of some endocrine disorders like pituitary gigantism, goiter, Graves' disease, and Cushing syndromes. The subsequent slide shows us some pictures of patients who exhibit these conditions. So we can see a 22-year-old man on our first one here with pituitary gigantism shown beside his identical twin, so you can see the physiological differences. We see someone with acromegaly, so excess growth hormone during adulthood. So look at the size of his ears, nose, and head. Another picture of goiter, so there's that thyroid gland swelling. Excess glucocorticoid, so excess cortisol as a result of Cushing syndrome. We get that butterfly effect, that reddening, pinkening of the cheeks. The exophthalmosis, the bulging of the eyes because of Graves' disease, so the buildup of fluid in that connective tissue behind the eyes pushes the eyes out. Lastly, we have our focus on homeostasis, so you can see what effect the endocrine system has on all our other mastery systems. So a nice little review to put everything together.